Okay, great. Hello, everyone, and thank you for joining us today for this webinar of determining the scope of guidelines. My name is Kirsty Watson, and I am the business developer lead here at Evidence Prime, and I will be the host of today's webinar. But first and foremost, I would like to introduce my colleague, Justine Litenska, the project management manager at Evidence Prime. Justina, would you mind just introducing yourself and a little bit about what you'll be speaking about today?
Yes, sure, Kirsty, thank you. So welcome everyone. My name is Justina, and today I will be speaking about the questions and outcomes generation in GradePro, which is a feature that accompanies the stage of scoping of a guideline, deciding on the topics that guideline will focus on. So our speaker, Tejan, will speak about the methodological background of this, and I will show you how this can be practically done in GradePro. I'm working at Evidence Prime and with GradePro for 4 years now, and I am mostly focused on helping the customers solve their problems, and also supporting sister projects such as the COVID-19 RecMap or the currently existing post-COVID-19 Canadian guidelines RecMap.
Great, thank you so much, Justina. And as Justina mentioned, we also have Dr. Tejan Boulder joining us today, who is a clinician and research methodologist at the McMaster Grade Center. Tejan, could you kindly introduce yourself and also briefly mention about what you'll be talking about today?
Hey there. Hi, everyone. So firstly, thank you for having me today. So my name's Tejan Balde, and as I was introduced, I'm I suppose a clinician, a researcher. Do a lot of my research based at McMaster University, and so I will be speaking today about question prioritization and outcome prioritization for guideline development. I'll be going through some of the theory around it and some of the practical issues that I've encountered in my work over the years.
Great, thank you very much. So as a GradePro team, we're quite familiar with the importance of scoping a guideline and how that it can become a bottleneck for many. And we're hoping that today's webinar will help ease the tension when it comes to the scoping of guidelines. And we look forward to both presentations today. So I'm just going to pass over to Dr. Boulder.
Okay. So today I'll be speaking about guideline scoping, including topics around question and outcome prioritization. So just before we begin, I have a few disclosures. So as was mentioned earlier, I'm a member of the GRADE working group at McMaster, based at McMaster University. I also have ties to Cochrane, Canada. I'm also a public health and preventative medicine resident at Queen's University in Canada. Then also important to disclose that I do receive consultancy payments from some of the guideline work that I'm doing, particularly from the European Commission and WHO. Another thing that's just important for me to mention is that some of the topics I will mention were focus of my academic efforts at McMaster. Was focus of my MPH thesis. So the specific objectives for today are to introduce you to the idea of guideline scoping and explain why it's important. And then specifically, I want to take you through the process of question prioritization and outcome prioritization. And as I said, I'll mention some of the issues that I've encountered, with some of the work that I've done in this field. And then I'll hand over to some of my colleagues from GradePro so that they can do a more practical tutorial about how you use the software to accomplish guideline scoping. And then finally, we'll open up everything for questions and address any queries that you have. So to begin, guideline scoping is really one of the initial phases of developing a clinical practice guideline. And it's where the scope is outlined and the purpose of the guideline is ultimately defined. There are three important questions that really guideline scoping aims to answer. So there's what topics the guideline will or won't cover. So a good example here is not just a disease, so not just colorectal cancer in this case, but getting a little bit more specific and talking about whether we'll focus on screening or management or diagnosis. These are all important decisions that are typically made at the level of a guideline organization. Secondly, it's to also decide on the intended audience of the guideline and the recommendations that will be formed. Will these recommendations be primarily for clinicians or other healthcare workers? Is it intended to inform policy, for policymakers to use, or is it primarily aimed for patients or other stakeholders? And then finally, we need to talk about which kind of healthcare settings, populations, interventions, and outcomes will become the focus of the guideline and ultimately evidence synthesis. Now, some of you, I'll get into it more specifically, but some of you may already recognize that we're starting to take the form of what's known as a PICO question here, acronym for population, intervention, comparator, and outcome. And so I've highlighted that question in blue because it really is the focus of question and outcome generation. It's trying to arrive at a PICO question. So why is guideline scoping so important? It's really important to go through this formal process of question generation and outcome generation. So that way we decide on a topic, and really it helps address areas where recommendations are needed most. It makes sure that the recommendations are relevant and ultimately actionable, which is one of the most important things of a guideline. It helps ensure that the workload is feasible. If we don't develop a very reasonable or feasible scope, then we won't be able to manage the workload, particularly in timelines, which can be tight in guideline development. It also helps facilitate data extraction and evidence synthesis. So systematic review teams will rely a lot on the guidance from guideline panels and some of the criteria that they develop in order to extract data and return back to the panel with evidence. And finally, it's always important with guidelines to be transparent. And so going through a formal process of guideline scoping it only helps to improve transparency of guideline development and improve the interpretation of recommendations and guideline for stakeholders. So here I've shown this is an older image that was developed at McMaster, just showing the guideline development process. I'm not sure if everyone can see my cursor, hopefully so, but I'll just draw your attention to the left side of the image here. I've highlighted two groups in red on the left side of the image, notably working groups and the guideline panel. The guideline panel and the working group are involved in developing, priority setting, a target audience, and question generation. There's also input from oversight committee and other stakeholders, which I'll speak about shortly. But this whole process of guideline scoping and question prioritization happens at the beginning of the guideline, and as I've said in the previous slide, ultimately informs evidence synthesis, which is in these blue boxes here. So the decisions that are made for guideline scoping are very important for evidence synthesis later on. And I think it sums up just with this comment here. It says, the quality of recommendations are only as good as the questions that are being asked. And so really that sums up the importance of guideline scoping. Now, before we get into the main points here, it's important to specify types of questions. So as I mentioned, there's an overall guideline topic, which I don't have listed in this slide. It was from a few slides ago, but things like colorectal cancer screening or management. And then when it comes to actually developing questions, typically guidelines will have guideline questions. So they'll just say that we want to compare two or more interventions. So an example of that, would be there'll be should questions. So should I use intervention A or intervention B in a particular population? Now, more specifically, there are evidence review questions. And these typically take on the form of the PICO question, which I was referring to earlier. If people aren't aware of the PICO question, it's population, intervention, comparator, and outcome. Those are the components of a typical healthcare question that would be addressed in guidelines. There are other types of questions that don't always take on the form of a PICO. Sometimes those questions they address issues like values or feasibility or cost effectiveness. For instance, what would be the values towards a particular intervention among a certain population of patients. So moving on to this slide, hopefully people recognize this. So this is a great evidence table. It's really a way of just summarizing evidence that's typically taken from a systematic review. So before I speak about it specifically, I'll just orient you to it. So at the top, you have the guideline question. So I have it in the first red box at the top. So for this particular example, they're comparing glucocorticoids compared to no glucocorticoids for critically ill patients with COVID-19. And then down below in the table, the evidence is summarized. So you'll find things, like your odds ratio, your certainty of evidence, and the importance. But what I want to highlight here in this slide is that ultimately the evidence is organized according to outcomes. So here I have 3 outcomes that were deemed important for this question, those being mortality, hospital discharge, and serious adverse events. So what I really want to highlight here is the difference between that guideline question where only 2 outcomes are being compared and the evidence review question where those 2 outcomes are being compared in the context of these 3 outcomes. And so now we'll move on to how do we actually carry out guideline scoping. So before we can do that, there's a few things that need to be in place. Ultimately, there needs to be an oversight committee that was selected by the guideline organization, and a guideline panel also needs to be in place. There also needs to be a process for identifying stakeholders. There needs to be a method decided on for arriving at consensus. And there also needs to be considerations around conflict of interest. So I'll speak about each of these next steps in the green boxes over the next few slides, but really what we're going to be doing here is performing a scoping review, doing a systematic search for different systematic reviews, for different guidelines, and then also consulting with stakeholders to try and inform how we generate our questions and outcomes. Then we move on to selecting our guideline topics. So this is typically done, at an organizational level. And then we move into question generation, where a list of, almost any and all relevant questions are generated. And then we prioritize those into the most important or the most important questions that we're going to actually address in the guideline. Similarly, we generate outcomes for each of those questions, all relevant outcomes. And then the next step is actually prioritizing those outcomes for each of the questions that were prioritized 2 steps prior. So we'll start going through this process now. So as I've said, the first thing really is trying to do a scoping review. So a systematic search should be performed. Typically what you're looking for here are existing guidelines on the proposed topic and existing systematic reviews. Some of the benefits from this are that, why do new work when there's kind of sufficient work out there? Sometimes guidelines can be adapted. And I think hopefully I'm speaking to fellow guideline developers here who have an idea of the work that's put into it. But developing a guideline and recommendations uses a lot of time, money, and other resources. And so when we can adapt these guidelines, it's important to do so. The other thing is that seeing what type of evidence is already out there helps us determine what's relevant, where we can make recommendations for questions where there's perhaps not a lot of guidance already and can make the most impact. So the next step that I mentioned was actually consulting with stakeholders. So firstly, examples of common stakeholders might be healthcare providers, other professional societies, policymakers, and members of the public or patients. That list is by no means exhaustive. There's many other examples of stakeholders out there, but these are just some of the common ones. I'll also just highlight that professional society specifically may also wish to partner with your particular guideline organization, and that's always welcomed. But there are issues that pop up, things regarding how conflict of interest is managed, and how consensus is going to be arrived at. These are all practical issues that have popped up from time to time in some of the guideline works that I've done. So specifically, some of the things that we can get out of stakeholder consultation is gathering input. So we can get key clinical questions and relevant patient outcomes, and we can also hear about implementation challenges. We can incorporate their perspectives. So it's not just about developing questions, it's about developing questions that incorporate the needs and preferences of these stakeholders that we're working with. We also need to address their concerns. Ultimately, they may or may not have concerns about some of the ideas and the questions that are being put forward. And so it allows us to hear their concerns and work with them in order to find a solution. And then another thing that I think is extremely important is really increasing buy-in and support from stakeholders out there. These recommendations are going to go out into the community, out into the world, and it's important that people believe in the work that's being done and want to use those recommendations down the road. So one thing that I mentioned is that being transparent is extremely important, and so a process should be used that's systematic, and that's ultimately described in the final guideline document. So some of the criteria that typically make for very good guideline topics are that it's a common disease or event. Perhaps it's an emerging issue, and it may have a high burden of disease, and that there's room for us to act. So really, we're looking for avoidable mortality or morbidity for the particular issue. Also, issues where there's variation in clinical practice are good topics to pick, and other areas where there's rapidly changing evidence as well. So now we move on to question generation. So as I mentioned, what we want to do here is try and develop a evidence review question as opposed to just a guideline question. So ultimately, what we're looking to do here is develop a PICO. So it's very important that when we develop this PICO that we're as specific as not as specific as we can be, but as specific as we need to be. And so this is where usually sometimes patient experiences or the expertise of the guideline panel is really welcomed, because we need to know what factors will ultimately make what factors will ultimately affect some of the decision making down the road. So it's really important that the guideline panel understands the process of how we develop questions and how we develop recommendations down the line. If we can foresee some of those issues, then we can, kind of get a step ahead, and we can address some of those things in our PICO question. So common things that might be relevant to describe for a population or disease stage or severity, other risk factors, diagnostic criteria, comorbidities, age, clinical status, and treatment history. Intervention and comparators I've just combined into one, but really, it's just about describing a specific medication, test, program, etc., whatever the nature of that question is. I won't speak about outcomes here because I'll defer it to a few slides, because outcome generation is a whole other part of this. And then sometimes settings are relevant as well, whether that be the type of facility like a hospital or a country. We're talking about specific populations, disadvantage versus advantage, etc. One thing that I want to highlight here about question generation is that it's a brainstorming step. So panel members should just generate a list of what's relevant, what they think may be likely to be important to patients. or stakeholders. It's not prioritization. That's the next step. So in my experience, typically when I go through these generation steps, what happens is, I may get 10 to 15 panel members who are generating questions, and they're not really using Pico format. Sometimes they're, questions can come in all different kinds of ways. And so it's usually my job as the methodologist to then go through and try and say, what are they really trying to say here? Trying to convert those questions to Pico format. Ideally, the panel members would do that on their own, but they need a little bit of a nudge or methodologist input in order to do that. One of the difficulties I found from a methodological point of view is trying to convert their initial questions into Pico format without really prioritizing things. In my own experience, it's been a fine line between generating Picos and accidentally prioritizing things a little bit. So here we'll just go through a bit of an example. So I've used an example of colorectal screening guideline questions. And here I have 5 questions on the screen. Should screening for no screening be used for early detection of colorectal cancer in asymptomatic average risk adults aged 50 to 69? I won't read all of the questions out, but these are all in Pico format. These are all examples of questions that are in the correct structure. And so I spoke about it on the previous slide, but some of the issues that I've encountered is that consensus can be very difficult. Questions are typically coming from all different types of topics, and they're all structured differently. And so it can be hard from a methodological point of view to assemble that into one single list at the end of the day. Typically, I work with the panel chairs or a steering group in order to do that and make sure that I'm reducing the amount of bias on my end. The other thing is that the list of questions can become very long, so it's important in order to manage workload, to try and narrow down the list a little bit if possible. So now we move on to this next stage of question prioritization. This is a very important part. So typically, GradePro can be used for this, but typically what's done is that questions are rated from 1 to 9, with 1 being the lowest, 9 being the highest, and they're rated according to the importance for the guideline and stakeholders. Now, once they're prioritized, typically the panel chairs, methodologists, and members of the steering group will really look at what are the timelines, how much work is going to be involved in developing all of these questions. Do we have the resources to answer all of these questions? And also ensuring that the questions have a little bit of flow to them, that they're all kind of related in some way. Now, one other thing that I want to mention that's very important is, as per grade methods, issues around feasibility, equity, implementation, acceptability, and cost effectiveness are all addressed in the ETD, or the evidence to decision tables, way down the line in guideline development. And so those questions around those issues typically don't need to be prioritized. They're developed, but they don't need to be generated or prioritized as part of these steps. So in my own experience, that's some of the instruction that I've given to guideline panel members, is that questions around these issues should just be left out in order to create shorter lists. So here I've just given a very mock example based on the same questions introduced on the previous slides, just regarding how I might prioritize these in the context of a colorectal cancer screening guideline. Now, this is a very simple exercise because there's only 5 questions on the screen. So as I've mentioned, these outcomes are typically rated by all panel members from 1 to 9. So here I've given examples of how they might be rated, based on my own experience. So 2 questions here that were rated 9 were specifically with regards to screening. Should screening or no screening be used for different age groups? So the difference here was for 50 to 69 and 45 to 49. These are almost certainly going to be relevant to a colorectal screening guideline, and so should automatically be included if we're able to manage that kind of workload. The next one here is, should personalized mail invitations compared to standard non-personalized mail invitations be used to recruit adults eligible for colorectal screening? Here I put a question mark because it may be deemed important by the guideline panel, or it may not be. And really, that's going to be one example of a question that might be addressed if you have the time or resources to. Other questions here regarding aspirin or smartphone apps for tracking bowel movements probably aren't going to be as relevant here. The aspirin versus no aspirin, it's more of a primary prevention issue, may not be as relevant here, so excluded. And the smartphone apps, again, probably not as relevant, probably not going to be a lot of evidence on it, and so should be probably excluded in the prioritization process. So now we'll move on to outcomes. Outcomes is where I do a lot of my work. That's where a lot of my research work is based. So typically, as with the question process, it's typically informed by the scoping review and stakeholder consultation. So really, we always look to adapt outcome sets where possible from the literature or previous guidelines. And we have a preference for using patient-important outcomes and avoiding surrogate outcomes where possible. So a typical example that's always used is coronary artery calcification, maybe a surrogate for myocardial infarction. But when we can measure myocardial infarction, that's what we would recommend. And then again, I've used the exact same text here, but just to emphasize that during outcome generation, we're listing what's relevant. We're not doing a prioritization exercise just yet. So here, again, I've used the example of colorectal cancer screening guidelines. I've just listed a bunch of outcomes that may be relevant and may be generated by a guideline panel. Some things that are really important, I find, for generating outcomes are things around outcome severity. So I'll draw your attention to the second to last row there. All three outcomes are pain, but we've separated them according to, first of all, whether it's acute, but second of all, whether it's mild, moderate, or severe. This is one thing that pops up in outcomes a lot, is that pain generally can be a single outcome, but sometimes guideline panels will suggest, oh, it needs to be split up into different severities or different, categories. And from a methodological point of view, it can be hard to tease that out and say, yes, it should be separated or it should be left as a single outcome. Typically, what we end up doing is going back to the panel with that and asking them or going through a consensus process to determine whether they should actually be separated. So again, I think some of the issues with outcome generation are the same as with question generation, in that I don't think guideline panel members typically understand, at least at the beginning of the guideline, how this information is going to be used down the line. And I don't think they always appreciate that the outcomes they generate now may or may not be used for evidence synthesis later and inform their development of recommendations, months down the line. So now I'll move on to outcome prioritization. So for each question that was prioritized in the steps prior, working group members will prioritize a list of outcomes. And again, these outcomes are listed from these outcomes are rated from 1 to 9, with ratings at 1 being limited to no importance to stakeholders or patients, and 9 being critically important to decision making for patients. So importance ratings should include values and preferences. And typically we rely on panel members' expertise, whether that be patient experience or healthcare expertise or a combination of the two, in order to arrive at a rating. Something else that's done is sometimes we look at health utility data for specific outcomes. So we'll have a systematic review team search for health utility information on particular sets of outcomes, or we will perform a health utility assessment among members of the guideline panel. So that way they have it in front of them and can use it to inform their rating exercise. So here, again, using the same example of outcomes, in yellow, I've shown outcomes that, in this case, might be rated as critical to decision making. So should almost certainly be included as part of the outcome set for this particular PICO question. And then in green, I've actually just highlighted something interesting that happens. So sometimes guideline panels will actually come to us and say that they want to develop composite outcomes. So in this case, all the different severities of pain and recall for assessment might just be included as harms. The reason there can be a variety of reasons for this. Typically, it's just because they're not expecting the guideline panel is not expecting there to be a lot of evidence on each of these outcomes, and they might not be able to develop a strong recommendation at the end. So some of the thought process is to combine them in a composite outcome where we may be able to still develop a strong outcome, a strong recommendation based on that outcome down the line. And so really, after all of that, we develop a evidence review question in the form of a PICO. So I've used an example of just one of them here. So for population, we're looking at asymptomatic average risk adults age 50 to 69. Interventions, we're looking at screening, and for comparator, no screening. And here we've prioritized a list of outcomes. We've developed an outcome set here, including the composite outcome harms, and no setting was specified. So this PICO question can then be taken to the evidence review team. They can extract the data and ultimately put it into an evidence decision table and work with the guideline to develop a recommendation for that healthcare question. So at this point, I'll move over to my colleagues at GradePro, and they'll take you through some of the practical applications of all this.
Great, thank you. Thanks a lot, Tejan. So yeah, now we will now I will try to show you how GradePro can support the process of guideline scoping that Tejan mentioned. As we all heard, it is quite complex, but also quite crucial for the guideline development. And I really like the expression that only good quality questions can create good quality recommendations. That's a very nice phrase. I will take that with me. I'm now in my project in GradePro. As you can see, the question list is empty. Around background 0 appears. So now I am still before the process of questions generation. However, as Tejan mentioned, there is a preparatory step before that. So I need to have someone to send that information to. I need to have my panel who will help me with prioritizing and brainstorming questions and outcomes, and I can do it in the team tab. And here I already prepared a list of people who will help me with that. I guess you may recognize some of the names that you see here, and you can also guess that those people. Well, it's very unlikely that Marie Curie has a GradePro account, but luckily she doesn't need one for this process. We recognize at GradePro that quite often people who are enlisted in the panel who will help prioritize and brainstorm questions. They are experts, they are patients sometimes, so they don't necessarily have time or skills to create a GradePro account and to use it, but they don't need to. They can just receive forms via email, answer simple questions in surveys, and this way they can provide their feedback. So this is quite easy for them and useful. Scoping has its own separate tab in GradePro, and it begins with a little outline document, which is maybe not compulsory, but quite useful to fill in with the title of the guideline, the purpose, perspective, target population, and other details that are worth to keep in mind throughout the whole process. However, we will move straight to the questions generation, and there's the first step that Tejan mentioned, which is actually you can start by giving the panel like a seed to go on to. sending an empty list to complete would be counterproductive, and also quite often at least some initial questions are known, especially if it is, for example, an update of an existing guideline, or simply because even the guideline team can know of some questions that are of interest. The questions here are taken from an older sister of the colorectal cancer project that Tejan mentioned, that this was the breast cancer guidelines by European Commission. And so this is an example of such a starting pool of questions that can be sent, and they are added very easily with just one button. The PICO format that Tejan mentioned is kept, so you can simply enter the intervention and comparison and health problem or population here, and this way create the question. However, it is also possible that if at the very beginning you're not quite sure what the PICO question should sound like, but you want to brainstorm it and then prioritize it nevertheless, you can use the free-form question, which just allows you to enter any content you want without necessarily following the PICO format from the very beginning. This option will also be later on available for the panelists themselves, especially if they are not specialists and they don't necessarily need to know the PICO format. So now that I have this starting list, I can simply send it to my panel members. And I will quickly show you what it looks like for them. So what they see when they open a link from GradePro. So they see something like that, a list of questions that was present in the previous step, but they also have options to add questions. When they add a question, so let's say, for example, that they want to suggest an organized screening as in the first example, but they want to include an older population than here. So for example, the first questions focus on women aged to 40 to 44 and to 45 to 49. But what about women aged 50 to 60, for example? So that's what the panel member can suggest, and those questions are highlighted so that they can remember that, okay, this is the question I added. They can also add questions or comments for the guideline developers to see, but what's quite important, they don't see each other's entries, so that way they don't influence one another's inputs, and this is all kept as unbiased as it can be. I have an example of a project where I went with this step earlier on, so that we can keep on coming. So here is a list of questions. As you can remember, we began with 6, and now there are 14, so 8 new questions arrived. Of course, in the real process, when there are even sometimes about 30 people in the panel, you can end up with even 100 or more questions. Of course, for today's webinar, we wouldn't have time for this. But once this question list is ready, once most of the panelists provided their input, you can close the brainstorming and proceed to the step called moderation. And the moderation is necessary because, as Tejan mentioned, sometimes people can, for example, repeat themselves. So here we see that someone suggested a question for women aged 50 to 69, and another person suggested the same question. So of course, to keep it tidy, we can remove one of those questions just to make sure that we don't have redundant questions. Also, someone here entered question in a non-PICO format. So someone asked, are emails better than letters for inviting patients to mammography? So of course, we can rephrase that question as PICO. So should emails versus letters be used for inviting asymptomatic women for breast cancer screening? So we can save this one, remove that question. And as you can imagine, this can be done. This can be done for any number of questions. Once the list is ready, once all the redundant questions have been removed, and also the non-PICO questions have been rephrased, we can move to the second step, which is the prioritizing step. And in that step, each panel member will receive another survey to go to. This time, this will be the 1 to 9 rating that Tejan mentioned. So every panel member will see the list of all questions that are left from the previous step, and they can mark their priority depending on what they think. So from 1 to 9, and then they can move to, then they can submit their votes. I will not be clicking through all of that to save time, but let's move to the next step. And the results will look like this. So as you can see, they are color-coded in 3 groups, meaning that following the GRADE guidelines, GradePro is coloring them. So the highest rated questions from 9 to 7 are marked as to be answered. So they will be answered with recommendations in this particular guideline. Then to be listed. So those with ratings of 6 to 4, they can be saved for the future. For example, if panel has more time at the end, they can focus on those questions. And if not, they can be saved for future guidelines. And finally, the lowest rated questions usually are the ones which are not relevant for the particular guideline. So as Tejan mentioned, for example, if the guideline is focused on screening and someone suggests a question on already primary care, then this question can be marked as excluded. And however, since the panel members themselves don't see the results, we need to make sure that they agree with our judgment, because, for example, we can even change it. So if I decide that this particular question, even though it got a lower rating, it could be still interesting for the guideline. So I can suggest for the panel to include it, or I can suggest to exclude another one. Once I do all of this and categorize the questions, I should make sure that the panel agrees with what I did, so I can send it for approval to the panel, and that is the last step of the process. And the form looks quite similar to the one shown earlier. So here there is the list of all questions in the 3 groups. So questions to be answered with recommendations, questions to be potentially important but not now, and questions with lower priority. And my panelists can either leave it as is, approving the priority, or they can decide that they want to change the priority, but in that case, they are required to leave a comment to this to say, for example, I want this to be answered, right? So if they want, if they think this is necessary, they can leave such a comment and submit their form. So of course, I have a project where such thing happened. And the panel and the guideline developer can see the results. What they do with these results depends on them. So we can say, for example, that of course, if 100% of people approve of the question, then of course it should be answered. If 93% approve, then yeah, that's also quite a lot. But here, for example, 20%, only 20% of people approve this particular rating. We can check in the comments that most of them left the TBA comment, so to be answered. So we can say, okay, if most of the panel believes that this still should be answered, we can move it to the higher group to satisfy their demands. And this can happen to any of the question depending on the approval rate. The last part is one of the most, let's say, easy ones, because now that the questions to be answered have been selected, the approval and the whole questions generation process can be closed and questions can be transferred. And that means that the questions will be automatically transferred to the comparison section. As you can see, it's no longer empty, no longer zero. We have 5 new questions. Inside each question, there is an evidence table waiting to be populated with outcomes, and later on the evidence to decision table ready to be populated with evidence. And that's how it goes. As you can see, it's quite easy and intuitive, and it doesn't require any outside sources. The process for outcomes works basically the same. So there are also 3. There are also 3 steps. So we begin with the initial list, then the panel brainstorms their own ideas, then they rate the outcomes, and finally they approve the outcomes. So I will not be clicking through all of this again. I want to only show the difference, meaning that outcomes, they don't exist in a vacuum, right? They are assigned to particular questions because they are how we measure the effects of interventions. So outcomes can only be entered if there are already questions here in the comparison section to be assigned to. So the same questions as in the comparison section can be found here. And what Tejan mentioned, sometimes questions can be grouped into topics. So for example, questions about mammography screening can be grouped together. Questions about inviting to screening programs can be grouped together, and the questions can be simply organized by dragging and dropping them. So that's quite easy, and this helps because sometimes not all questions can have the same outcome. So mortality can be used for both groups, but for example, if I want to add an outcome which is attendance rate for the screening, then it will not match the mammography itself, but it will very well match the invitation strategies. So that's where we may want to add it, and this way we can add more outcomes and then go through whole of the process itself. So that will be all from my end for now, and I think I can pass to Kirsty and to Tejan as well in the question session.
Great. Thank you so much to you both for your insightful presentations. We do have a few questions that have popped up, and I see that Tejan has been answering a few of those. So just the few that he hasn't gotten around to, I'll just start off here. In setting the PICOs, do you suggest defining a geographic location? Can you detail it, or could this limit the inclusion criteria?
Yeah, so I think I think this person has really kind of hit the nail on the head here, in that there can be a fine line between giving too much detail that actually can affect how data is found and extracted out of the evidence base. So for instance, if data is limited based on a particular healthcare setting or a country, the systematic review team might not find any information based on that criteria. So really, that's why we look to the expertise of the guideline panel in developing these PICO questions, because they should anyway have an idea of generally what the evidence base is, where that evidence might be found from a setting point of view. They hypothesize about the level of detail that needs to be in the PICO questions.
Okay, great. Thank you so much. And I have a few questions here for you, Justina. The first being, is there a limit to how many questions can be brainstormed? I'm assuming this is within GradePro.
Yes, it is. And luckily, or it depends how you approach it, there is no limit. So people can suggest as many questions as they want. Of course, in the end, you have to select a finite number of questions. If not for the limit of GradePro subscription, then certainly for the fact that you can simply answer like 50 questions or more. It's usually the usually taken number is at the end is around 20 or 10, depending on the budget and the time. But during the brainstorming, as many questions as you want can appear, because as Dejan mentioned, we're not prioritizing at this stage. We are just gathering ideas.
Okay, fantastic. And is it also possible to check how every panel member voted?
So maybe for this particular one, I will temporarily go back to sharing my screen, because yes, this is quite possible. So I think it was this one. Yes, so here we can see the ratings, and there is option to show individual ratings. Of course, the results are anonymized, because it is not suggested to show who voted in which way. This also helps to keep from bias. So you can see how each question has been rated, what's the mean result, what's the median, which is presented later on, the minimum, maximum vote, and everything here. So it's all available here.
Okay, great. And also, I believe for Justina, how many members can be added to this software? Is there a limit?
So in the free version, available for everyone, because the feature is available for everyone, but in the free version, the limit is 3 people, including like the owner of the project. So I imagine it may not be ideal for the number of panel. However, in most of our subscriptions, the limits start with like 15 people. So that's already quite a nice group to work with, and they can be often negotiated. So we always adjust it to the needs of the panel that appears, the needs of the project. So, but we usually start with 15, and then see if this needs to be expanded for a particular project.
Thank you so much. I see we have less than 5 minutes remaining, so let me try and quickly get through the rest of these questions. I have one for you, Dr. Boulder. You mentioned to avoid utilizing indirect outcomes. Can you expand on this? Do you typically write no evidence measured in the evidence profile, or do you still attempt to find an indirect evidence?
I think my personal point of view, I don't think, not everyone might agree with this, but my personal point of view is we just look for the best evidence out there. So that's why I said avoid. So if you're able to find data on the exact outcome, my preference is to use that. I think using surrogate outcomes brings in a degree of indirectness, which, as I'm sure most of you know, is something that's considered in the evidence appraisal assessment and can lower the quality of recommendations. So that's the reason why I advise avoiding them where possible. I recognize that that's not always possible for a variety of different reasons. So I suppose, just to answer your question specifically, if a surrogate outcome is the only thing you have available, in my own opinion, that's better than nothing. It may result in a weak recommendation, but it's a recommendation nevertheless. And I think that's really the whole point of GRADE at the end of the day.
Okay, great. And I see you may have started to answer this other question, saying, Tejan, you mentioned about setting in the PICOs. Is there a way to adapt the existing guidelines to specific countries? Like, for example, adapting North American guidelines to LMICs?
Yeah, so here I think they're referring to low and middle income countries. So I suppose I was a little confused just by the question. When I don't know if the person asking it is able to actually to respond to this or not. I was a little confused by when they meant adapting. So do they mean just taking topics to inform your own topic prioritization, or are they actually talking about taking actual recommendations? I suppose I'll use the former here because I think it's probably more relevant to guideline scoping. I think you can use former guidelines. I think the topics will always be relevant, but really that's where we rely on the guideline panel. So what you can do is you can search for a specific guideline, let's say a North American guideline in this case. If you're developing a guideline for LMIC, you can propose a set of questions or outcomes, whatever stage you're at, and have a guideline panel rate the importance, or during the generation stage, they can even add or remove elements as they see fit. So it's a way to incorporate the panel's expertise and still, draw on. I'm sorry, there. I'm just seeing the person's responded, I think.
I believe like implementing.
Like implementing. I think he means from like a policy point of view with regards to recommendations. So I think, that would typically, that kind of gets a little bit more complex. I think it's a little bit out of the scope of the discussion we're having here. The short answer is yes, there are ways to, kind of adapt evidence, but it incorporates, different, there's bias, in terms of adapting recommendations. And that's also kind of the jobs of policymakers as well, to look at that evidence and implement it appropriately. But I won't go into that for the sake of this presentation.
I will just shortly add that the whole process of adapting so the development, right? Adaptation, adaptation, and de novo development is a very complex one. We do intend to touch on it in one of our future webinars. So we encourage everyone to just stay in touch and to subscribe for the newsletter, because this is an important topic and certainly will be considered in the future.
Okay, fantastic. Unfortunately, that is all the time that we have for today. If there are any questions we hadn't gotten to, or if you have future questions for us, feel free to reach out to us at GradePro or Evidence Prime, and we'll be happy to help. But thank you so much, Dr. Tejan Balde and Justine Linska, for your presentations, and thank you to our audience as well for joining us today. I hope you all have a lovely day further. Thank you very much. Goodbye.